There we are, and we're there. How about that? Big
We are
excitement.
live.
This is a rare occasion that I'm early, Dr. Bond.
Really?
Yes, I need credit for this because it's Maycember. Are you familiar with this term?
No, you're the first person I've heard it from.
Well, I won't take credit for inventing it. I think it was actually the Holderness family, but
Okay.
Maycember is very similar to December, but it's worse.
It's worse.
It's worse because it's like the whole world, there's everything you have to do like 100 times 100.
Mm-hmm.
Award
Mm-hmm.
ceremonies, field trips, Mother's Day,
Yeah.
and I can't even, there's too many things.
There's just too many to count.
There's too many things. So we are going to get started. I'm going to put up my little comment here while y'all jump on, which I'm excited about.
Yeah.
And there we go. Period. Look at everybody hopping on here. I'm so impressed. All of y'all are so timely. Okay, we're going to star this comment. There we go. So today's session was brought to you by Covaris, MedIQ with support from Covaris. We are talking with Dr. Rachel Bond, who is a cardiologist. Welcome, Dr. Bond.
Oh, thank you so much. I'm looking forward to our discussion.
Well, I'm really excited too. So I'm going to explain the format. We're going to do a little Q&A, and we're going to have some questions from guest viewers. Y'all are not allowed to start asking questions now. That's very early. And anyway, it's going to be fun, but you can submit your questions, and I'm going to be trying to follow them. And I hopefully am going to have a couple friends that might be sending me text on my phone if there's some really important ones to see. See, this is like double technology time. So I'm Adrienne Wood. My platform is Tales of an Educated Debutante. I know many of you, and I've worked with MedIQ, who is a fabulous partner on medical platforms. And I've said it's really been kind of a health changer for me. I've lost 30 pounds in the last year. I quit smoking. Ugh. I mean, it's been a lot of changes. And I really do credit getting to talk to these awesome physicians, and really, it makes a difference when you have a conversation with somebody and it's not a random article in AARP. So I'm glad you're here. Dr. Bond is a board certified cardiologist who really, you've devoted your career to the treatment of heart disease through early detection, education, and prevention. And you're also a national spokesperson for the Go Red for Women campaign. What is that?
Yeah, so the Go Red for Women campaign was created by the American Heart Association in about the year 2002. The goal of that campaign was to really raise awareness that cardiovascular disease is the leading cause of death and the leading threat for us women. And back in the day, and even still to this day, many women don't understand that cardiovascular disease is their greatest threat. So through this campaign, we hear stories of women who may have had complications during all stages of their life. And most importantly, it's really to raise awareness of how to prevent something like heart disease that is largely preventable.
So you just said that's the largest risk of death for women?
Yes.
Well, I had missed that memo. I thought it was breast cancer.
Exactly. And, when we put it into perspective, we know that whereas about 1 in 30 women die from breast cancer, 1 in 3 die from heart disease. So just thinking about our own household, where there possibly are 3 women within each household, at least one of us will pass away from cardiovascular disease. And our goal is to ensure that that's later on in life, not prematurely. And most importantly, understanding that it is largely preventable. And I will say that even the American Heart Association has highlighted that through their campaign, although more women understand that cardiovascular disease is their greatest threat, still to this day, women don't really understand that it's not just a risk for them, but it's also a risk for others in their family in terms of the hereditary component of cardiovascular disease. The American Heart Association did a survey where back in 2009, they surveyed a series of women, and they saw that about 30 to 40% of the women then understood that heart disease was their greatest threat. And then when they compared it to a survey for those 10 years later, it was significantly lower. And the group where it was lower was younger women, and particularly women of color, where we are actually seeing the highest rates of cardiovascular outcomes. And when I use the term cardiovascular, it's important to understand what that means. So that means issues of the heart, potentially issues of the arteries in the brain, which could lead to a stroke. And if there are issues in the arteries of the heart, that could typically lead to a heart attack. And then we also know that there are arteries in other areas of our body, like our upper arms, our legs, and that would be something termed peripheral arterial disease. So even though that is our greatest threat, again, it's so important to highlight that it's largely preventable. Oh, you're muted.
I muted myself in case my family didn't abide by my be quiet rule. This is real life around here working from home. So I said, okay, let's talk about prevention. I'm 48. I know that smoking is a good thing to stop. So I can say that with confidence that I have stopped that. I've lost some weight. What are some other things that we need to do?
Absolutely. So when it comes to women, it is important to highlight that all of those risk factors you mentioned, those more traditional risk factors, absolutely impact women just as much as they do men, but actually some of them may impact women even more. So let's use smoking as an example. So if you're a female who has smoked the same number of cigarettes for the same duration as your male counterpart, you are actually 25% more likely to have cardiovascular issues. The same way, if you have high blood pressure, as women, they tend to be less aggressively managed for it. Therefore, the impact of it is larger. Similarly, high cholesterol impacts women greater than men, and having a history of obesity or being overweight actually largely impacts women much greater than men. It's also relevant to highlight that women have more female-specific risk factors, and many of these have a lot to do with our reproductive years. So if we go through menopause early, if we have any complications during pregnancy, if we choose to have a pregnancy, such as high blood pressure in pregnancy, a condition called preeclampsia, where your blood pressure may become very elevated and it could be dangerous for both you and your baby, or even gestational diabetes, those are all risk factors in the future for heart disease. So understanding what your risk factors are what allow us to make cardiovascular disease largely preventable, because we can pinpoint those risk factors and then in the end work on ways to reduce the risk of having elevated blood pressure, cholesterol, obesity, and of course smoking, something that we typically are able to help our patients wean off of with the goal to stop altogether.
So some of what I heard you say too was not just that we're like genetically predetermined, but that women's high blood pressure isn't managed as well as men's?
Exactly. And this is one thing, hence the reason I really wanted to dedicate my career to women's cardiovascular health, because there are so many disparities when it comes to not just the diagnosis, but also the treatment. We know as it stands right now, women are usually either underdiagnosed or there's a delay in diagnosis. Many a times, if a woman comes to the emergency room with a classic heart attack, they're told they're having an anxiety attack. So there is a lot of unconscious bias that I will say still exists in medicine. And we as cardiologists, particularly through organizations like the American Heart Association, are trying to get the messaging out there to educate our clinicians that heart disease is an equal opportunity killer, and we have to take our female patients just as seriously as we take our male patients.
That really makes sense when I hadn't thought about it that way, but I always do feel like even in my own family, it's been like the men with the heart troubles.
Yes.
And it kind of makes sense too, like women are just supposed to suck it up, buttercup, and keep on moving, you know?
Exactly.
And maybe women are so busy taking care of other people traditionally that they're putting themselves on the back burner.
100%. And that is a very, very important and poignant statement to say, because one other additional risk factor that I didn't point out that's not really traditional is the stressors of our role as women. And as you said, many a times we are the ones that care for the family, either it be our parents or our own family that we create, even our friends as an example, and even sometimes professionally. And as a result, there's a lot of burden that places on you. And we know that stress can increase one's risk for cardiovascular complications, and that does disproportionately affect more women than men.
Huh. Well, that's not totally shocking,
Of
but
course.
worrisome. So what are the other signs and symptoms you mentioned when somebody goes to the ER? What should I be on the lookout for? Because I have
Absolutely.
preeclampsia. I'm like, oh, I didn't know that was a risk.
Of course, and many women don't actually know that those risk factors or those conditions that happen during their pregnancy can possibly lead to cardiac issues later on in life. But absolutely knowing what the signs and symptoms are one easy way for us to diagnose the condition early and most importantly work on the best treatment. So what are the signs and symptoms? I will tell you that the vast majority of women do present the same way men do when it comes to a heart attack, which is that discomfort that's in the center of the chest. We see it all the time in the movies, right? Where someone's clutching their chest and they go in, they say, I feel like an elephant sitting on my chest. However, many a times women have additional symptoms that may be more subtle. So they may feel a shortness of breath. Instead of having pain in the center, they may feel more pain in their shoulders or pain in their neck or even pain in their jaw. I'll also highlight the fact that indigestion or like a burning sensation in your upper belly, that also classically could be a sign that a heart attack is pending. And then lastly, tiredness and fatigue, things that all of us experience. But if that tiredness and fatigue doesn't go away, particularly if we're getting the fair amount of sleep that we should get, and we know that there's no other cause of it, that also could be a warning sign that there's something going on with the heart.
And is that different to men? Like, do men have that kind of fatigue?
So men may, but many a times it's disproportionately higher in women. There are some conditions where men may have more of those less classic symptoms. One common one are in our diabetic patients who may not have as well controlled management of their blood sugar. But for the most part, those more subtle symptoms like tiredness, the shoulder discomfort, the shortness of breath, that tends to happen more in women than men.
And how about what's the average age?
Yes. So we know that as our age increases, our risk of heart disease increases. And the rule of thumb usually is postmenopausal women. So typically, on average, women usually go through menopause at the age of 55. Of course, there's some that are a little earlier, some a little later. But 55, typically any female above the age of 55, that's a risk factor for cardiovascular disease. And all you need is one risk factor to have cardiovascular disease. And it's important to highlight that about 90% of women have at least one risk factor for cardiovascular disease. You did bring up genes and the hereditary portion of heart disease, because I highlight that because 55 may not be the time that you present. If you know that heart disease runs in your family, it's extremely important that you're getting your numbers like your blood pressure and your cholesterol and your blood sugar checked probably as early as possible, because if your family member, your first degree relative, like your parents or your siblings, had a heart attack as a female before the age of 65 or as a male before the age of 55, you may be at a higher risk of having heart disease a little earlier than the general population. So knowing your family history is really, really important.
And you said, well, Holly Webb said at 47, I had a heart attack due to 2 pulmonary embolisms.
Okay.
So just because you're 50, if you're under 55, it doesn't mean you're good to go, right?
Exactly. And that's why knowing your risk. And I will say that there are different types of heart attacks. Ones that could be associated with pulmonary embolisms may be more related to the high burden of clot that was in the lungs that put a strain and stress on the heart. The heart attack that I'm referencing is the one that has more to do with an unstable plaque that's in the arteries of your heart, and that plaque ruptures and leads predominantly to a heart attack, not that there's a secondary driver that led to it.
So this is kind of a question as we're going through some of these risks. Leslie Ward said, I've had pain in my shoulders, up to my neck, my jaw, aching pain, not regular, but occasional. How worried should I be? My dad died of a massive heart attack at 51. So go through these risks again with us and tell us, like, I am tired. But when do you know when the line of tired is to you need to get checked out tired?
Yeah, and what I always like to tell women in particular is that we know our body best. If something isn't normal and if something doesn't seem right, it's extremely, extremely important that you speak to your healthcare professional, your trusted clinician, and ask those questions. Is it possible that these subtle symptoms that I'm experiencing are as a result of a cardiac condition? If you have risk factors, particularly a family history, as we mentioned, we've heard, 100% at a minimum, we should be having you undergo tests. And an easy enough test that the primary care clinician can do is an EKG, which is a little sticker of the heart that allows us to see how the electricity through the heart is moving. That could be an early sign that there's something going on and that additional testing is warranted. So for anyone who has risk factors, family history, elevated blood pressure, high cholesterol, diabetes, even borderline diabetes, overweight, a history of obesity, and some of those more female specific risk factors like the preeclampsia, the gestational diabetes, or even premature labor. Just spontaneous premature labor of pregnancy could be a risk factor for cardiovascular disease as well. It's extremely important that if you're having those signs and symptoms, you speak to your trusted healthcare professional.
Okay. That's really good to know. I had no idea. What about COVID? How does COVID play into this?
So COVID absolutely plays into this, because the one thing I will highlight is that many of the risk factors that place patients at a higher risk of getting COVID-19, particularly the severe form of it, are the same risk factors that lead to cardiac disease. We also know that COVID-19, like any infection, can actually increase the risk of cardiovascular disease. The thing about COVID-19 that's interesting is that it leads to this inflammatory surge. And the thing about heart disease, particularly at the level of the plaque, is that it is inflammatory. That's why many other conditions that cause inflammation, like lupus, rheumatoid arthritis, things that disproportionately affect more women than men, also lead to premature heart issues. So if you're feeling symptoms and you had either COVID-19 or any form of inflammatory condition, similarly, it's extremely important that you talk to your trusted healthcare professional and clinician about should you be tested from a cardiovascular perspective.
So what you're saying is the burden of disease really is different in women.
100%. And you know, I don't think that the general population understands that. And
I
it's
don't think they do.
yeah,
I'm raising my hand again.
and it's
But
definitely
tell us about that again, because I think that is super big to me.
It's extremely big, and it's something that I would love the audience to actually take home today understanding, because the thing about cardiovascular disease is that we as women have more risk factors than men, unfortunately, because not only do we have those traditional risk factors, but we also have those risk factors during our reproductive years, as I mentioned. Even women who go through menopause a little earlier on in life, on average, that would be before the age of 45, that can place you at a higher risk of having a cardiovascular complication. Therefore, the burden is higher. The burden's also higher because, as I noted above, unfortunately, more women are less aggressively treated for heart issues. They're less likely to be given the classic medicine that we know can lower their chances of having a cardiac issue. And more importantly, if they had a cardiac issue, prevent them from having a recurrent one. So it's for that reason, again, that we in the women's cardiovascular specialty are really trying to educate our healthcare colleagues about the importance of treating women, yes, uniquely, but just as importantly, as equal as we do our male patients.
Well, and it's interesting you said that. Ann Dale Homestead just said it's difficult to get a physician to listen to a woman that goes in being tired and having aches and pains. And I agree with you, Ann. I think we've all had that experience. Like, I'm tired. Well, of course you're tired, and I say that same thing to myself. Like, of course you're tired. You've got 4 children. You've got one with autism. It's May, it's stressful. Of course you're tired. You're busy. But we also have to advocate for ourselves. And I love that. What is my body telling me?
Yeah.
What is my body telling me?
Exactly. And one thing I will add to that is that if you feel as though you're not being listened to, getting a second opinion, getting a third opinion, right? There are options out there that you can do. You want to make sure that you're working with a healthcare team that you trust and that also trust you, because it's not just about listening to women. We have to believe women as well. And I will say that that is the biggest area where I see that there are discrepancies in that is when there are complications during pregnancy. So with pregnancy, as an example, heart disease is the leading cause of death for many of our new moms, which is really scary when you think about it. And many a times the reason is because these mothers are not just listened to, but they're also not believed when they say that there's something going on with them. So this is why it's extremely important that you are with a healthcare professional that you can trust.
And, I think at least if it's me, I love to have conversations with my healthcare providers when something's not happening, just to kind of have this precursor conversation or to share a little bit about myself. Like my son who has autism, I knew at 10 days old that he was different, and I will tell that story sometimes just to kind of showcase the fact that my intuition was right, and to encourage women to follow their intuition, but encourage physicians to listen. Like, she knows,
Mm-hmm.
and I don't know how much data there is on that because I think it's kind of like, well, we thought, but it's important. It's super important.
Absolutely. Oh, no, you're 100% right. I mean, there is actually some data where women who had gone over and over and over to the emergency department and were dismissed, told that it's their gastric system, told that it was anxiety, and then came back with a massive heart attack. We know that those outcomes are obviously significantly worse because there was a delay in something so largely treatable, such as a heart attack or a cardiac event. With that being said, I will tell you that we have restructured a lot of our education right now when it comes to medical school as well as nursing school, because it's a combination of both the doctors as well as the nurses in terms of identifying these conditions earlier on in the course, and most importantly, listening to the women and believing them. So I am hopeful that as we continue to do more sessions like this, women also will understand what the signs and symptoms to look out for are. That way they can advocate for themselves and say, do
Right.
you think I'm having a heart attack? I always tell my female patients that if you're having chest pain and you're being dismissed, you have to ask that question because they can't ignore that question. They cannot ignore the fact if you bring to their attention that you're concerned you're having a heart attack. So you have to ask and pose that question.
Hmm. And tell me, how does it work for women of color?
So it's actually significantly worse for women of color. So when it comes to cardiac disease, we know that the leading group that's having the worst outcomes are women of color, but particularly Black women. When we see Black women above the age of 20, we know about 60% of them have some form of cardiac disease. It's largely driven by all those risk factors I mentioned, like the blood pressure, the diabetes, the obesity, and the cholesterol. But why is that? And a lot of that has to do with the social aspects of their living environment. Limited access to medical care that is not only accessible, but also is from an equal perspective, something that we know is favorable. And we also know, of course, that a lot of it has to do with those stressors that I referenced, because as Black women, many a times there are the stressors of being a Black person living in America, where the racism comes with that, but also being a female in America, where the sexism comes with that. So because of that sort of double-edged sword, there's a lot of that chronic stress that leads to premature heart issues, leads to
Mhm.
all of those risk factors that I mentioned. And then we have to factor in the lack of listening. And that's where we see the lack of listening the greatest when it comes to the healthcare profession. And a lot of that has to do with, unfortunately, unconscious bias, where Black women are just not as routinely listened to as other populations.
So one example of that may be what I would understand is if you're, and I mean, I'm a white female and I've experienced it somewhat, but you're obese, you've eaten too much, like, well, have you thought about exercising? Those kind of like questions, which didn't we, my understanding was 20 years ago, you weren't treated with medicine for blood pressure. Weren't you just kind of told to exercise and eat better? And now we don't do it that way anymore.
So I will tell you that first and foremost, eating healthy and exercising is always the first treatment, right? And we know that we
Okay.
could have immense improvement in all of those risk factors like blood
Right.
pressure, obesity through that.
Right.
But as you said, we really need to acknowledge the fact that obesity is a chronic medical condition, just like high blood pressure and high cholesterol, because if exercising and if eating healthy are not enough, we shouldn't have to stop there. We have now options. We have medical options and we have surgical options. And that's where, again, working with a trusted healthcare professional is important, because they'll talk to you about those options that can significantly lower your likelihood of having a cardiovascular outcome. I bring up the limitations sometimes also of exercise and eating healthy, because just factor in those social aspects. If you can't afford to eat healthy, you're not going to eat healthy. If you don't live in an environment where you can safely exercise outside, you're not going to exercise outside. So it's really important that we ask our patients what those limitations are and then work with them to figure out what we can do, or at least what guidance we can provide them to lower their likelihood of having these issues.
And what else? What would you say? I like that. What else would you say to say, how do we lower our stress? Like when I tell you that I'm in December and I'm kind of up to here with like, I have a paper calendar, I have my phone calendar, I have alarms going off, like, don't forget. How do I have to do those things to function, but how can I lower my stress level?
Yeah, that's a hard question, right? Because that's easier
Tell me
said
you
than
have a
done.
magic answer. Yes.
I'm trying to figure it out myself.
Okay.
But one thing I can say for myself is that I typically have always in the past said yes. Yes, I will do this event. Yes, I will do this for my family. And now I'm realizing that there is a point in my life where I need to be a little bit more selfish. And I think that we as women have to start becoming a little bit more selfish, where we have to say, maybe instead of me doing these 10 tasks that I do every month, I'm only going to do 8. And then the next month, I'm only going to do 7. Then the next month, I'm only going to do 6, right? Prioritizing what events, what tasks are really indicated, and then perhaps removing the other things that are not. I will say that there's power in saying no also. I've always said yes, but now that I'm saying no, I feel that it has really allowed me to focus more on the time that I need for my self-wellness. Mental wellness is such an important aspect of physical wellness. So if you're stressed and overwhelmed, your body's going to feel it. Your blood pressure is going to be high. Your cholesterol is going to be out of whack. Your blood sugar is going to be out of whack. So it's really important that we focus on those mental aspects. That way we can ensure that our physical aspects are perfect.
That's really important.
Yeah.
So one thing we talked about the other day was enrolling in these clinical trials. Can you talk more about that as women?
Yes.
Like who would enroll? How do you do it? Why is it important?
Yes. So I will tell you that the only way we're going to figure out how to best treat women is to have research that are specific for women. Historically, when you look at all of our cardiac research, it predominantly has been on older white men. And we know, of course, that the United States population is much more diverse than that. As it stands right now, there are multiple clinical trials that have only enrolled about 30% women at best. And a lot of them have to do with heart failure, which is a weakened heart muscle, or if we have issues with the arteries in our heart. Our goal really should be 50% women, 50% men. And then when we look at the women and the number of women who are enrolled, we see that it's even less when it comes to women of color. And I will tell you that a lot of that has to do with the mistrust of the healthcare system. But more importantly, we as clinicians are not targeting this population, and we do have to do a better job. So a lot of centers out there and a lot of hospitals are creating research studies that are specific for women. I reference the American Heart Association because I do volunteer my time with them, but there are so many other cardiovascular societies that have a lot of research studies, and you can actually, just by Googling, figure out what those research studies are so you can decide if you have any reason to be enrolled in them, perhaps getting more information.
Well, it's funny you said that. Terry Davis just said, I participated in a clinical trial in blood pressure treatment and got paid for it too. So
Yes.
that's kind of neat that you can do that. I feel like whenever I sign up to take particularly one of my children to the doctor, I'm always getting kind of an email of, we've got this study going on. And so again, it's knowing that it's important and will help other people. It's
Exactly.
nice to know. And when we talked about, I want to go back to this disparities in care a little bit with heart health, because we talked about race, which wealth, but insurance disparities. So what if somebody doesn't have insurance and they are concerned about their heart? What do they do?
So, there are options. However, it's important to highlight, as you said, that those that are uninsured absolutely have worse health outcomes. We even know when it comes to the greatest driver of our health outcomes, it's our zip code. So, where we live and where we grew up as well, it dictates what our health will look like in the future. It's interesting because I just had I present at several conferences, and I had the opportunity to present last weekend at a conference where we talked a little bit about the genetics and the genetics behind cardiovascular disease. As I said, there's a hereditary component to it. But when you actually look at our genes as humans, we are largely the same, regardless of our race, regardless of our ethnicity. So
Oh, I didn't know this.
99.9% of our genes are identical. The 0.1% is what makes it different. And that has to do with the environment that we grew up in. But it's that 0.1% that could be the difference of living a healthy, normal life and dying at the age of 95 or 100 versus prematurely dying because of where you grew up. So I do think it's important to acknowledge that. And then going back to your statement about insurance being uninsured, 100%, that's another driver, because when you're uninsured, you're less likely to be offered sometimes these life-saving medications because you can't afford them. Although there are options out there for us to help our patients as best as we could, there are limitations.
Mm-hmm. And I live in a pretty rural area, and
Yeah.
it's, I would imagine, harder to get an appointment here. I mean, if we're one provider down, we really feel it. I mean, everybody will say, "Well, they're gone this week. What are we going to do now that we're sick?" I mean, it's a town of 5,000, so and you're not, right beside a big health center, heart center kind of thing that you need.
I was going to say, just in referencing rural areas, a lot of them are what we call cardiac deserts, which means that sometimes rural areas don't even have a cardiologist in their neighborhood. And obviously, that's highly concerning. And they may have to go long distances just to see a heart doctor, which makes it a lot harder for them to get actual care.
Right, right. So now I'm thinking, like, do I need to go get my heart checked? What 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 do I need to do? Not that this is all about me, but what treatment is available for everybody? So if everybody leaves tonight and says, "Okay, I have one of these risk factors," what should be the plan for me?
Yes. So one thing is that my goal was not to scare you, of course, right? It's important that you understand your risk factors, you understand the signs and symptoms, and you understand that heart disease is our greatest threat. However, it's also important that you understand it's largely preventable. 80% of the time, we can prevent bad issues from happening and heart disease altogether from happening. So, how do we do that? So, as women, we really need to go every year for our well woman checkup. That's where you'll get your blood pressure checked, you'll get your cholesterol and your blood sugar, and somebody will also talk to you about your weight, your exercise. I can't emphasize the importance of 30 minutes every single day of some form of moderate physical activity. That could include walking at a brisk pace. So I always tell my patients, we shouldn't have any excuses when it comes to that cardio and that exercise. And then, of course, that professional will also talk to you about a healthy, heart healthy diet and lifestyle, making sure you're not smoking, ensuring you're not drinking alcohol in excess, and really honing in on your other more less traditional risk factors, like the pregnancy issues, the family history, and then determining if you need to have any additional testing outside of just doing blood work. If you do that, and if you make sure that all of those more traditional risk factors are under better control, you're less likely to have issues in the long run.
And these yearly appointments, would that be with your OBGYN or would that be with a general physician? Who should that be with?
So I do encourage you that if you don't have a primary care clinician, that you do have the ability to seek one. The reason being is
Okay.
that although during our reproductive years, many a times the obstetrician and the gynecologist act as our primary care
Right,
clinician, we
right.
know that as we age out of that reproductive years, we will no longer have the opportunity to see them. Maybe we will, but I know many of them will recommend that you transition to somebody else after. And there could be challenges in transitioning to a new provider. So you might as well stick with a provider with the opportunity to kind of be with them for the long haul, because then they'll know you, they'll know your history, they'll know your risk factors. They have a comparison year to year, and that way they can make sure that things are under well control. So I really do encourage those that don't have primary care clinicians out there, at a minimum, you should absolutely get a primary care clinician.
And one thing you told me the other day, which really stuck with me when we were kind of talking about this call and what we were going to be talking about, was knowing your numbers. And that really hit me hard because well, this might not be a good thing to admit, but no news is good news is sort of my mantra. And
Yeah.
it really hit me that maybe that wasn't the smartest thing.
Exactly. So when you're doing these annual visits, it's not only important to get these numbers checked, like the blood pressure and the cholesterol and the blood sugar, but actually understand what those numbers mean. I will tell you that everyone's different in terms of what our goals should be. So ask your healthcare professional, well, what is the goal for me based on my medical condition? Should my blood pressure be XYZ or should it be something else? That way you can keep track, even if you decide at home, to ensure that those levels are staying at the goal and not above the goal.
Okay. That's really good to know.
Yeah.
Do you need your own like blood pressure machine?
So, not everybody does. However, for people who have a very strong family history of high blood pressure, who also have issues with high blood pressure in the doctor's office, it is strongly recommended, because there is a condition called Whitecode hypertension, which means when you see a white coat, your blood pressure gets high. So, it's usually in a healthcare setting, and then at home, it's normal. And it's really important that we differentiate that from normal high blood pressure, because we, in that situation with white coat hypertension or white coat high blood pressure, we may not recommend medicine. But if you have high blood pressure in the doctor's office as well as high blood pressure at home, then we may recommend medicine if lifestyle isn't enough. So not everybody needs a blood pressure machine, but I do like to err on the side of being extra cautious. And I do believe that knowing more information, particularly for the betterment of your health, is actually good.
Yeah, I would see that. I, that seems like it would make sense because when I go to the doctor, they'll say of course, I know nothing of what the numbers mean. Is that normal for you? And I'm always like, I don't know. So it would be good for me to know.
100%.
Or to say, well, what does that mean? Is that number high? Are you concerned? Is it good? Is a high pulse rate a risk? Tamara asked.
So a high pulse rate many times could be a reaction to what your body is experiencing. So
Okay.
that's where it's important to ask again your clinician, well, why is my heart rate elevated? Is it because my thyroid is overactive? Is it because I'm on a specific medicine that could be driving that? Or is it because I have something else inside my body that's driving my heart rate to be elevated, such as my blood count is low, I'm a little iron deficient? I mean, there's several things that an elevated heart rate could be the cause of. I will tell you that a lot of times it's a reaction to something that's going on, like an infection, sometimes maybe dehydration. But if your heart rate is elevated more times than not, it is important that you ask your healthcare clinician, have you looked to see why this is the case? Do we need to make sure that it's not the heart that's driving this as well?
Would you say, when you were talking about walking earlier, I walked one day last week and it was amazing how it lowered my stress level, like for
Yes.
exercise and that. But I love the 30-minute thing because I think in my mind, I think I've got to go for an hour. And if I can't, I might as well not go. I'm just
Nope.
going to watch TV.
No, so exactly. Again, all you need is 30 minutes, and it's actually a minimum of 5 days a week. I always like to say every day, but it really has to just be that minimum of 5 days a week if you wanted to take the weekend off and bum around the house. But it's important that when you are walking, you're walking with a purpose, right? So that's where that brisk walking comes into play. Because when it's leisurely walking, yes, that's better than sitting on the couch, but that would be more low impact exercise. When you're briskly walking, that's more moderate impact. And that moderate impact is what lowers that cardiovascular risk.
Well, I believe it. For some reason, it's like you have to start the process and then you remember how good it is.
Exactly. And you're right, because exercise releases happy hormones, which are called endorphins, and they
And I
help
had more
reduce stress.
energy that day.
Exactly.
So it's interesting. We'll do a couple of these things and see if you're still tired. Well, I was like, well, I'm really a lot less tired now that I went and walked. It's counterintuitive to me somehow. We've gone through a few questions. These people love to ask some questions. Could you speak to and educate about heart beating irregular symptoms or AFib? What is AFib?
So atrial fibrillation is when the top chamber of our heart, instead of beating minute to minute, it quivers. And many a times, what happens with atrial fibrillation is because that top chamber of the heart is quivering, blood can stay in that top chamber and it could create a clot. And if a clot is created in the heart, that could break off and go to the brain and cause a stroke. This is why, for patients who have a history of atrial fibrillation, we tend to put them on blood thinners depending on what their risk factors are. If, as one ages, their risk increases. If they have high blood pressure or diabetes or a prior history of a stroke, that actually increases. And even being a female puts you at a higher risk of having a blood clot form as opposed to our male counterparts. So that may be another reason why we add on a blood thinner. The thing about atrial fibrillation that people have to realize is that when we age, the risk increases. And for the rule of thumb is actually for those above the age of 70, about 1 in 8 people have this condition. And although it can increase your risk of stroke, it's largely preventable when caught early. So many a times people may feel an irregular or fluttering sensation in their chest. The way we diagnose it is by having you wear a monitor. It's called an event monitor, which is usually a little sticker. And depending on how often you're feeling your symptoms, the doctor will determine how long you should wear the monitor so we can capture it. Once captured, we also may consider screening you for other things that we know can put you at a higher risk for AFib. One common one is sleep apnea. And sleep apnea is definitely important to know because it's underdiagnosed as well, more in women than men. And what happens with sleep apnea is that during the nighttime, you have periods of time where you stop breathing. You don't realize it because it's very brief, but your body realizes it, and it's under under strain and stress. And because it's under strain and stress, it makes you more at risk of abnormal heart rhythms like atrial fibrillation.
Wow, that is really big. What about vape? I like to talk about this because this hit me today. So people that have quit smoking, what about people that vape? Is vaping safer than smoking for heart problems?
Yes, I get this question all the time. And I
You're
will
not going to
tell
like the
you,
answer, people. I already know.
yeah, so the answer is no. So the thing about vaping is that it still has those same substances in it that the cigarettes have. And the main things that we worry about with those substances, nicotine predominantly being one of them, is that it's getting to the level of those arteries and it's causing inflammation. Every time you take a puff, it's not just going to the lungs, but it's going deep into those arteries as well. And it's causing damage, and that damage builds up more and more and more. We know as it stands right now, there is an epidemic of vaping. We talked about this. Younger and younger people are experiencing vaping just because it's so easy to have access to it. And that's very scary for me. And, I will say that there are a lot of campaigns out there that are trying to get the messaging about the dangers of vaping, because people, of course, not just adults, but also children, think it's safe just because it's not in the form of a cigarette. But we know the answer is it's not safer. If anything, it may be even more dangerous because of the fact we think it's safe. So really educating yourself about what you're inhaling inside of you and talking to your healthcare professional is going to be important.
Yeah, I think that's really key, especially those of us with teenagers and knowing that, it used to be that you smelled like cigarette smoke. Now you just can kind of blend into the distance. That'll bring up our stress level. Well, Dr. Bond, I just really appreciate you coming on tonight, and thank you, MedIQ, for hosting us. This was really informative. I think people have loved it and just said, Dr. Bond is so easy to understand, which I think is super important, that we can just have a conversation and it doesn't have to be a textbook.
Exactly.
Right?
Exactly. Yeah, exactly. That's the goal, because we want to make sure that you understand and that you take home all these really important messages. Again, my take home for this would be that, yes, heart disease is our greatest threat, but again, we can prevent it. Making sure you see a trusted doctor or clinician that can check all of these tests every single year, tweak things if needed, exercise, eating healthy, all of that can help to reduce the likelihood of having bad outcomes.
Yeah. Well, thank you again. And thank you, MedIQ, with support from Covaris. It was just really, really helpful. And I'm going to go make my next doctor's appointment so I can get all my numbers, and then I'm going to know what they are.
Yay.
But thank you. I hope you have a good night.
You too. Bye-bye.
Thanks, everybody.
Bye.